Hello, Dr. Card and fellow classmates. My name is Julia Hines, and this presentation is my Practicum project final report regarding the results of an intervention I implemented with a population of patients contending with chronic non-malignant pain. We'll begin with an introduction of the background of my patient education intervention, the healthcare organization, and the learning objectives. Next, I will discuss the feedback I received from the surveys and interviews I conducted. I will present the methodology and evaluative measures used for my project. I will share with you my project results and reflections of lessons learned and my recommendations for improvement, and we will end with a summary conclusion. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Chronic non-malignant pain, or CNMP, is pain that on average continues 3 months or longer, persisting continuously or episodically after the original injury or damage is healed, and often without a definitively known cause or etiology. Once considered a symptom, CNMP is not classified as an independent diagnosis affecting 1 in 5 people in America. The brain's plasticity turns on the patient and becomes chronically maladaptive, where the noxious stimulus etches a pain memory in the nociceptive pain pathways of the brain. This means the brain actually learns pain and begins to associate pain with benign actions, behaviors, and events. CNMP causes changes in personality and dietary intake, mood swings, debilitating immobility, increased morbidity, exacerbation of pre-existing diagnoses, changes in the brain and central nervous system, pernicious challenges to the cardiovascular system, and negative psychosocial mental health outcomes, including suicidality, resulting in decreased well-being and quality of life. The intervention population was 5 pre-screen adults, 4 women and 1 man, aged 30 to 81 years old, receiving care in an adult and family medicine, or AFM, primary care department, which brings us to the second introductory element. The healthcare organization in which the intervention took place was Kaiser Permanente, or KP, East Bay Medical Center. The specific environmental setting for the intervention was Pinole Medical Office Building, MOB, AFM department at KP East Bay Medical Center. Each of the 4 learning objectives represent the focus of 4 separate therapeutic patient education encounters. The 4 learning objectives aim to improve patient engagement, patient empowerment, and patient motivation. I created 2 stakeholder survey questionnaires based on 2 assessment tools from the Center for Accelerating Care Transformation, which is a research center of KP Washington Health Research Institute. Survey patients revealed a consensus of receiving low quality patient educational material, or PEM, that was deficient in inclusive cultural competence, patient centeredness, understandability, relevance, applicability, and helpfulness, and notably inconsistent provision of PEM from physicians requested by patients. Surveyed care team member revealed a consensus of a systemic communication breakdown within the care team, resulting in inconsistent practice, an unfavorable perception of the current PEM, often opting to forego using it in clinical practice altogether, and the need to transform the current PEM and teaching methodology. There is no interprofessional collaborative care team, or ICCT, in AFM. There is no registered nurse involvement at all in AFM within the care management and education of patients with CNMP, only physician and medical assistant dyads. Surveys from both groups reveal current PEM consist of a computer printed general after visit summary template with occasional website link, KP issued generic pain and chronic pain flyers found in exam rooms, non patient centered educational bullet points of general information delivered under the constraints of limited timeframes by physicians, providers, and medical assistants, all who do not specialize in therapeutic patient education. Social determinants of health revealed in patient survey questionnaire responses included difficulty accessing PEM, difficulty receiving PEM that is aligned with learner style and ability, poor access to a direct patient care and education, poor access to patient-centered focused care partnerships, insufficient online competency, lack of technological literacy, and deficient knowledge regarding CNMP pathophysiology and management best practices. Educational strategies used in the development of my project included an andragogical approach, motivational interviewing, the therapeutic alliance model, and referring to the patient educational pain management toolkit published online by the Oregon Pain Guidance Group. all of which provided the scaffolding for my intervention. Assessment and identification of patients with CNMP triggered this teaching plan. A thoughtful discussion about pain, CNMP, and management possibilities was introduced, supplemented by PEM that was specific to CNMP and the patient's current situation. Analogous to the nursing process, my teaching care plan consisted of ongoing continuous adjustment and evaluation based on patient need. The five subject areas included CNMP, the role of cognition and emotion, medication safety, self efficacy, and sustainable self care management. Researching the subject of CNMP patient care and educational best practices, I discovered the Oregon Pain Guidance Group associated with Oregon Health Authority. The website contains PEM regarding CNMP self care management and self care efficacy development. Using the pain management toolkit as a resource, I created a threefold introductory patient educational pamphlet on CNMP as seen here, designed to open the conversation to the possibility of a different life with CNMP that is better than what the patient has currently. The physician who partnered with me during the intervention pre screened five patients in the AFM department for appropriateness and amenability. After a brief introduction that included a presentation of the current situation regarding pain science and CNMP care in the AFM department at KP, I engaged in listening far more than talking, opening a dialogue to the patient's current understanding of their CNMP, its course and action plan thus far, and their most pressing concerns and challenges. The introduction consisted of meeting patients where they are at with regarding to their CNMP, providing transparency about KP's opportunity to do better by them. The threefold pamphlet was given to the patient for careful review. This was followed by an open discussion about its content during which the patient expressed motivations and goals, in turn guiding my invitation to empower patients to first consider their capability to enact positive change in their own lives. I provided education regarding the long held misconceptions about pain and CNMP by the medical community, and that the brain's plasticity can be hijacked by chronic maladaptive pain signals, where the pain is not all in their mind, but it is in their brain. I explained that this means the brain actually learns pain and in turn learns how to create more pain despite lack of injury. My message was punctuated by the hopeful silver lining found in neuroplasticity. The brain can change, only the patient holds the power to do so, and these methods can help patients to rewire their brains to disassociate benign actions with threat and pain. Transparency was provided in acknowledging that I did not think I would be able to transform their lives with a single educational encounter or a single pamphlet on CNMP. Rather, that the shift in cognition and emotional response will be a process, and these materials are designed to facilitate long term success on their journey towards positive health outcomes and well being. After that, I shut up and I let the patient before me talk, and it did not take long for the patients to open up. Once patients demonstrated openness, receptiveness, and were amenable to further pain care collaboration, the handout on understanding pain seen here was given to the patient for careful review, followed by open discussion and invitation to explore the corresponding video, as well as the remaining handouts and videos on the website as they see fit. I emphasize that it was the materials that were being evaluated and not the patient. This slide shows a thumbnail of the introductory educational video on pain for patients with CNMP. I was provided access to a vacant physician office with computer access, which provided an inviting, private, safe environment that facilitated comfort, security, and invitation for open dialogue and accessibility to a computer. Therefore, I was able to demonstrate on the computer for the patient how to get to and navigate the website if he or she desired. I used the teach back method to evaluate individual learning and used the Kirkpatrick framework to evaluate the population's experience, achievement of the first learning objective, their intention to modify their behavior based on the intervention, and organizational outcomes from the intervention. All five patients had a positive reaction to the intervention, expressing positive feedback both during and at the completion of the encounter, demonstrating investment in continued learning and understanding more about CNMP self care. The target population was able to demonstrate learning objective achievement by successfully verbalizing in their own words a working definition of CNMP, including reasons why their own pain continues in the face of negative diagnostic findings and the lack of current injury or disease. All five patients verbalized intent to modify their behavior based on the intervention. All five patients verbalized intent to view the patient educational videos, read the corresponding handouts, carefully review the entire toolkit on the website, and agree to follow up with their doctor regarding developing a personalized care plan. I was unable to allow patients to keep the pamphlet I created because it was not KP branded. They were only able to read and return it. They were, however, able to keep the handout from the website because this content is published in the public domain. I'm unable to shed any light on any implemented performance improvement at the micro level, specifically in the AFM department, because accurate evaluation at the fourth Kirkpatrick level requires summative outcome assessment, not possible given the time constraints of this practicum course. To recap, evaluation methodology for learning outcomes, it consisted of teach back where patients were able to demonstrate meeting the objective. There were no barriers to learning and all patients responded well to the individualized teaching, which was presented in a conversation rather than a lecture. Feedback included some uncertainty about their ability to change or rewire their brains, but each patient was willing to open his mind to the possibility of positive change. All verbalized comprehension and intention to watch and explore the videos, handouts, and overall content on the website, and confirmed they will follow up with their doctor for further pain care plan development. I've all 5 patients demonstrated well-developed health literacy, reporting competency in navigating the KP healthcare system, to which all attributed to a baseline minimum 10-year KP health plan membership. The project population had a positive reaction to the intervention and expressed positive feedback throughout the encounter. Meeting the first learning objective demonstrated a transfer of knowledge and understanding among the population as a result of the intervention. Verbalizing intent to modify their behavior further expressed their willingness to engage in exploring strategies to cultivate independent self care management. Many lessons were learned throughout this project. Partnering with one engaged physician who shared my premise and appreciated the project's impetus worked well with the target population. I prepared a formal report detailing the education improvement intervention in the form of a collated program booklet with a professional report cover for the physician to review prior to me embarking on any patient encounters. I had a preliminary discussion with this doctor regarding the purpose, goals, and guiding aim of the project, which provided opportunity for exchange, discussion, debate, and networking. The partnering physician pre-screened the 5 patients, as I said before. This was key to the success of the project implementation, which highlights the need and functionality and benefits of having an ICCT. Allowing me access to a vacant office with computer access was key also. It provided accessibility options for teaching and learning. The lighting and temperature was left a lot to be desired. There was only one solitary overhead light, which was not adequate or adjustable. Despite opening the window blinds to allow lighting, the weather sky did not produce enough light. Upon further inspection, I observed other doctors actually brought in their own lights to supplement. The space temperature was low. I observed the several patients occasionally bristling and readjusting the outer clothing. This can affect their ability to listen, process, learn, as well as influence their pain. Not being allowed to let them keep the pamphlet truncated the intervention, and that they were not allowed to reread and review the content at home. Finally, the inability to schedule the patient educational encounters created a haphazard workflow and uncertain time frame allowances between each patient. Despite my best efforts to not convey time constraints, it might be possible that it was shown through to the patients. Ways to improve upon this project would be providing more time, creating a schedule for an actual RN educator, integrated health coach, creating packets of educational content to give to the patients that allows for tailoring and journaling that can be integrated later. Creating a comfortable, inviting private space separate from an exam room would actually be conducive to open dialogue, and obtaining access to audiovisual technology would actually facilitate video viewing, online patient educational content during the encounters, which would be more meaningful in person instruction, hands on learning, and accessibility options. The core of this project improvement for this intervention is nursing, calling for the creation of an interprofessional collaborative care team that includes an RN educator, integrated health coach. Therefore, the main area for improvement resides with the current organizational system. The following slides are my references for this presentation. And I would like to thank you for your attention, for listening, and I'm looking forward to your thoughtful feedback. Have a good rest of your day or evening.